The Weekly Pelvic Health Research Review, July 10th, 2026. Hello, I am Erwin Leeuw, a physiotherapist specializing in pelvic health. This week, 68 publications were screened and 35 were retained. Two features structure the program. The first follows obstetric perineal injuries from prevention to postnatal follow-up. The second asks a practical question. Can ultrasound, manometry, and questionnaires genuinely objectify pelvic dysfunction? This review provides general scientific information and does not replace individual medical decision-making. Feature 1. Obstetric perineal injury. What should be measured before, during, and after birth? The central publication is the new IUGA International Guideline on Obstetric Anal Sphincter Injuries. Its abstract was not available in this week's dataset, so its individual recommendations cannot be described reliably here. Its publication is nevertheless significant because it brings detection, classification, repair, and follow-up of obstetric sphincter injuries into a single international framework. Mechanical prevention is addressed by a meta-analysis of Epischisser's 60, designed to produce a more consistent mediolateral episiotomy angle. 8 studies were included, but only 2 were randomized. 6 reported fewer sphincter injuries. In the pooled analysis, use of the scissors was associated with a 2 percentage point absolute reduction in injury across all vaginal births. Among women who actually underwent episiotomy, however, the reduction was not statistically significant. Episiotomy rates were also unchanged. The findings, therefore, do not prove that the scissors themselves protect the sphincter whenever an episiotomy is performed. The authors suggest a possible Hawthorne effect. Introducing a new instrument may alter training, attention, and technique across the whole maternity team. Prevention also begins before labor. A review of preventive pelvic floor muscle training reports favorable evidence for antenatal training in women who are still continent, particularly for reducing urinary incontinence during pregnancy and after birth. Evidence is less definite for offering the same postnatal program indiscriminately to all women. The article also identifies a mismatch in the United States. Preventive antenatal training is supported by trials and meta-analyses, yet insurance usually pays only once a dysfunction has developed. Another paper examines what is rarely captured in an obstetric record: the woman's experience of the second stage of labor. The new second stage of labor questionnaire, or SOL-Q, was developed within a multi-center trial of 1 midwife versus 2 midwife assistants. It was sent to 2,831 first-time mothers after vaginal birth, and 2,221 responded. Its 16 items cover 4 domains: coping and empowerment, decision-making, pain perception, and safety and vulnerability. Scores were poorer among women with fear of childbirth, oxytocin augmentation, or a second stage lasting more than 3 hours. No domain differed between women supported by 1 or 2 midwives. The SOL-Q does not measure a sphincter tear, muscle force, or prolapse stage. It measures what the expulsive phase was like for the woman. 2 clinically similar births may therefore produce very different experiences. Feature 2. Ultrasound, manometry, and questionnaires. What are we actually measuring? A study of 747 women compared pelvic floor morphometry on 4-dimensional translabial ultrasound in women with and without persistent pelvic pain. 469 reported pain. Their levator hiatus was smaller on average during Valsalva. Differences were more marked among women currently receiving treatment for pain. Women with deep infiltrating endometriosis also had smaller hiatal areas at rest and during Valsalva. This does not create an ultrasound diagnostic threshold for pelvic pain or muscle overactivity. Group averages differed, but the distribution overlapped too much for individual diagnosis. The scan describes a group phenotype. It cannot establish that a small hiatus explains one patient's pain. The same problem appears with 3-dimensional, high-resolution anorectal manometry. 47 patients were assessed before and after fistulotomy for a simple perineal fistula. At 12 months, 26% reported worsening continence, despite no change in average sphincter pressures. Some regional pressure patterns differed, but not sufficiently to predict postoperative continence reliably. A more sophisticated pressure map, therefore, does not justify routine manometry before every simple fistulotomy. Its role may be more relevant in complex fistulas, where more sphincter tissue is at risk. Objectification may also use a questionnaire, but its value depends on exactly what it measures. The second revision of the Toileting Habit Profile Questionnaire explores sensory factors affecting toileting in children aged 3 to 6. Parents of children with and without functional defecation disorders completed the questionnaire. The hyperreactivity subscale had acceptable internal consistency with a Cronbach alpha of 0.755. The hyporeactivity or poor perception subscale was weaker at 0.616. Both nevertheless distinguished children with functional defecation disorders from those without. This is a developing screening instrument, not an established diagnostic test. It explores sensory participation in toileting, which ultrasound and manometry do not measure well. The three studies lead to the same conclusion through different routes. Anatomy is not automatically function. Mean pressure does not necessarily predict continence. A questionnaire is only valid for the specific construct it was designed to assess. This week's must-reads. The first must-read concerns pelvic floor muscle training for pelvic organ prolapse. A meta-analysis included 16 randomized trials. Compared with control interventions, pelvic floor muscle training reduced the pelvic organ prolapse symptom score, increased maximal surface electromyographic activity, and improved muscle endurance. Women more often reported improvement, and some anatomical outcomes, particularly overall stage and anterior wall prolapse, also improved. No clear benefit was found for posterior wall prolapse or modified Oxford grading. Effects were mainly demonstrated within 6 months. Beyond 6 months, and among women aged 55 years or older, results were no longer statistically significant. Training therefore improved several short-term symptoms and functional measures, but equivalent evidence is lacking for every compartment and for long-term durability. The second must-read is a sham-controlled trial of vaginal microablative radiofrequency for overactive bladder. 140 women aged 45 to 65 with overactive bladder or urgency-predominant mixed incontinence were randomized to 3 radiofrequency sessions or 3 sham sessions. Both groups also received behavioral therapy. Symptoms improved in both groups, but active radiofrequency did not provide superior improvement in the primary outcome at 6 months. This is the value of a sham procedure. Without it, improvement shared by both groups could easily have been attributed to the energy treatment. In this trial, the active procedure did not outperform sham plus behavioral care. The third must-read examines continence after post-prostatectomy radiotherapy. A planned secondary analysis of the randomized RAVES trial compared immediate adjuvant radiotherapy with salvage radiotherapy triggered by a rising prostate-specific antigen level. Patients receiving adjuvant radiotherapy more often reported clinically important worsening in bowel symptoms than men in the salvage group who ultimately did not require radiotherapy. At 5 years, 16% of men in the adjuvant group reported severe urinary incontinence, compared with 2% among men who received no radiotherapy. Among men who did receive radiotherapy, however, its timing was not significantly associated with urinary, bowel, or sexual outcomes between 1 and 5 years. The main functional difference was therefore between receiving and not receiving radiotherapy, rather than between 2 radiotherapy schedules. The fourth must-read concerns dysynergic defecation and fear of movement. Among 120 adults with dysynergic defecation, more than 90% had kinesiophobia. Higher scores were associated with pain during and after defecation, constipation severity, pain catastrophizing, depressive symptoms, and poorer quality of life. Pain catastrophizing was the strongest predictor, and the regression model explained 71% of the variation in kinesiophobia scores. The cross-sectional design cannot establish whether fear contributes to dyssynergia or repeated painful defecation produces fear. It does show that coordination training alone may leave a major driver of avoidance untouched. The fifth must-read concerns early home catheter removal after urogynecological surgery. 128 women who failed their initial postoperative voiding trial were randomized to self-removal at home on day 1 or on days 3 to 4. Persistent urinary retention occurred in 14.1% of the early group and 10.9% of the standard group. The difference remained within the predefined non-inferiority margin. Satisfaction was high in both groups, and complication rates did not differ. Properly instructed patients may therefore be offered day 1 removal, rather than automatically undergoing several additional days of catheterization. Brief reports. A prospective multicenter cohort of 419 men found that regret 1 year after radical prostatectomy was more strongly associated with urinary and sexual outcomes than with prostate-specific antigen recurrence or surgical approach. 54% felt erectile function was worse than expected, and 23% felt continence was worse than expected. In apical prolapse, a large matched cohort found more prolapse reoperations after native tissue hysteropexy than after hysterectomy with apical suspension, 11.1 versus 6.5%. Overall retreatment, including pessary use, was 15 versus 9.6%. Hysteropexy was nevertheless associated with slightly less early urinary retention and fewer urinary tract infections. A separate national cohort with 3 to 14 years of follow-up associated sacrocolpopexy, with the lowest patient-reported symptom burden after vaginal vault suspension. Some procedures, including sacrospinous fixation with graft and ipsilateral uterosacral suspension, had poorer outcomes in selected domains. Because treatment allocation was not randomized, the differences cannot be attributed entirely to surgical technique. Finally, among 118 women undergoing total hip arthroplasty, urinary incontinence improved mainly during the first 3 months and then plateaued. Of 73 women with preoperative incontinence, 45 remained symptomatic at 1 year. Hip replacement may coincide with early improvement, but it is not a reliable treatment for urinary incontinence. Conclusion. This week's papers separate 4 levels that are often conflated: injury, morphology, measured performance, and lived experience. They may move in the same direction, but not consistently. The treatment trials make a related point. Improvement without a sham comparison does not establish the specific effect of a technology, and a satisfactory anatomical result does not guarantee satisfactory function. See you next week for another pelvic health research review.